So good afternoon, everyone. I'm Sandra Rushton. I am faculty in the Berman Institute of the School of Nursing and co-chair of the Johns Hopkins Ethics Committee Consultation Service. And I want to welcome you to Ethics for Lunch. This is a series that is co-sponsored by the Berman Institute and the Hospital Ethics Committee. And it is designed as a forum to engage our community in discussing ethical issues that are coming up in our own practice. So I want to welcome you today. We have a very interesting panel today, and it reflects some of the trends that we are being asked to participate in as an ethics committee. So today's topic is the intersection of decision-making capacity and mental illness. And I'm going to turn the panel over to Mark Hughes, who's the co-chair of the Hospital Ethics Committee. Thank you, Mark.
Hi, everyone. Welcome to the new academic year for Ethics for Lunch. We hope to see you every third Tuesday of the month. Just a reminder, we had a handout that gives the case, as well as details about what the Berman Institute is, what the Ethics Committee does, and there was a separate sheet for code for CME, or just want to acknowledge your attendance. And it's also up there, so if you text 443-541-5052 and then put in the code 16705, that will register with My Learning, and then you'll be able to see that you attended, and CME will see that you were here as well. So helpful if you can do that. So I'm going to have our panelists introduce themselves. So maybe we'll just go down the line. You can say a little bit about what you do in your everyday life, and then how you're involved with the ethics committee.
So I'm Pat Triplett. I'm the clinical director for the Department of Psychiatry. I'm also on one of the FIPS teams. These are proactive psychiatric consultation teams that operate on the 3 of the general medical floors. Actually, it's 6 now. We have 2 different teams, and I lead one of those 2 teams.
My name is Allison Trimble. I'm a member of the Ethics Committee and I'm assistant professor in the Division of Pulmonary and Critical Care Medicine. I'm Lori Mostovsky. I'm a senior social worker in child psychiatry, and I'm also a member of the Ethics Committee for a year and a half now.
Hi, my name is Amelia Simmons. I'm a member of the Ethics Committee and a nurse on Minor 9, which is a GI medicine floor, and I cared for the patient that I'm discussing today as a bedside nurse. And then there's a side caveat, I am working, so I will have to dash out a little bit early. My apologies.
Okay, so what I thought we'd do is I'll read the case, and because this should be a dialogue between you and us, and really trying to get your input about these kinds of cases. And this is not all of the details of the particular case that we did do an ethics consult on, but sort of an amalgam of things that were going on with this patient that we thought would be relevant to thinking about this intersection of decision-making capacity and mental illness. So I'm going to read it, and then I'm going to invite your comments of how would you approach this, what concerns do you have, are there particular details you think we need to explore, and so on. So, all right, so this is John Smith, 25-year-old male. He has a bloodstream infection, so he has sepsis, thought to be secondary to an infected bile duct stent that had been placed for a previous episode of cholecystitis, so a gallbladder biliary tree infection, and then that stent was placed to try to relieve that obstruction. The medical teams recommended intravenous antibiotics and removal of the stent, since it could be a continuing source of the infection. If it got seeded with infection, that could continue to be a problem for the bloodstream infection. The patient has refused to have the endoscopy procedure to remove the stent, saying that invasive procedures worsen his mental illness. Over the course of the hospitalization, he has refused other aspects of his care plan, including sometimes daily nursing care, blood draws for lab tests, IV line placement, blood transfusions for anemia. He had lots of other illnesses, comorbidities, and it became a challenge each time he would refuse of things that they thought he needed. He has agreed to the plan for IV antibiotics, but on certain days, he'll postpone that. He'll say, you know, I'm not ready for my infusion just yet. It was timed infusion, or some days he would just outright refuse it. So it also became difficult to manage this infection. The healthcare team is concerned that his refusal of the GI procedure could lead to worsening of his condition and potentially even die if this bloodstream infection weren't adequately treated. So Mr. Smith has an extensive psychiatric history, including a personality disorder and bipolar affective disorder. He has autism spectrum disorder and cognitive rigidity. He has a history of suicide attempts and self-harming behavior, and he currently denies any depression or suicidal ideation. It was in the back of the healthcare team's mind of, does that prior history sort of influence how he's thinking about these refusals nowadays? But he does say he wants to get better and continue on living. He states that he currently understands that he could die if he refuses the recommended procedure to remove the stent. He says that he's refusing because the medical procedures and the anesthesia that he gets for the procedures cause him to have really negative thoughts. And those thoughts make him want to hurt himself, just try to escape these negative feelings that he experiences afterwards. So there has been a psychiatry consultant seeing him. They have been of the opinion that right now there are no current psychiatric issues that would preclude the medicine team, his physicians, nurses, and others, from completing a capacity assessment on their own. So each decision that he's making, they should do a capacity assessment to decide whether he has the capacity to make that particular decision. And the medical team, based on their discussions with the patient, do feel that he retains this decision-making capacity. So the healthcare team is concerned on a few different fronts, but they're concerned, how do we manage his care if he's to go into septic shock? You know, if he really is getting sicker from this infection, after he's been refusing what we think is needed procedure, needed interventions, and given the background of his mental illness and his past self-injurious behavior, the suicide attempts and so on, they want to know, from ethics, an ethics consult, what should we do? What are we obligated to provide him? Do we allow him to die if he's getting sicker and becomes unconscious and loses capacity? Is it ethically appropriate to go against his wishes and then start to treat him once he does lose decision-making capacity? So these challenges that the team is facing, both his current care and his refusals, and then looking into the future, how do we take care of him if things get worse? So let me turn it over to you all. If you have comments, questions, suggestions, and Alan's going to go around with the mic, and we'll wait for the mic to get to you.
You mentioned that they wanted to do IV antibiotics as an intervention. Was there an option for less invasive, like pill form of the same type?
For the kind of infection, the particular bacteria he had, it required IV antibiotics.
Could you talk a little bit more about what's involved in that evaluation to determine if the patient is actually...
Can you speak up?
could you talk a little more about what is involved in that evaluation to determine if the patient is capable of making their medical decisions and if there is no psychological illness influencing those decisions?
Okay, so two aspects of that. Fred, you want to?
Yeah, I can say this loud. Are there any...
use the mic.
Are there any caregivers or family members that are with the patient to help make decisions?
And you're asking more for the idea of trying to assist him in making decisions. I'll answer that question first. He's estranged from his parents. He does have a friend that he relies on to discuss decisions, but generally he likes to make the decisions himself. So has some communication with his friend, but otherwise is on his own. Does anybody in the audience want to answer the question, how would you assess capacity to make decisions? So there are two aspects, just general capacity, how do you do that? And then if there are a psychiatric history or psychological factors, how does that bear on that assessment? Anybody have a quick guide as to how to determine capacity? we have experts up here that I can rely on, but anybody? Yes, sir.
I'm the only lawyer in the room, but I do training on advanced directives, and I'm on the Sinai Hospital Ethics Committee. But I understand capacity or what capacity would be is basically to be able to hear or receive a communication to and related information as to the medical condition and the potential treatment, be able to process internally that treatment, the risks, the potential benefits, weighed against the person's own preferences and needs, be able to ask questions, receive communications, and then to finally make a determination based upon the individual's preferences, based upon the risks and benefits, and then the last step would be to communicate in a way that's appropriate for the medical healthcare providers, communicate what they want. Basically, the short thing is give informed consent or withhold informed consent.
Okay, that sounds great. That covered it all. Anybody want to add to that?
Yeah, so that A plus. So there was a paper in the New England Journal, probably in the last 10 or 15 years, that finally kind of brings it all together. That in psychiatry, that we sort of look at as the touchstone for that, and it's just those elements that you mentioned. So they're basically 4 parts. So are they able to communicate a choice? Are they able to understand the information that you're discussing? Do they appreciate their situation and the implications of decisions that they're making? And finally, can they demonstrate to you that they're able to reason and think about the choice that they're making and explain it to you? So that's, you got all those points.
Based on the description of the case as it's been presented, does anybody want to weigh in of whether he met all 4 of those criteria? Just the bare bones sort of description of how he was making decisions and refusing?
I think it would be easy to discount his decision-making as being against his best interest, when in fact he is very much arguing in his own best interest with the information that he has in hand. He's able to outline what the negative consequences for him, potentially fatal, are of placement of an IV or other medical interventions, given that he knows one of the side effects to be psychiatric distress. So I think that it's important to not diminish his listing of those possible consequences as being less real or less cogent than the medical consequences.
Yeah, so he's demonstrating an understanding of the information. He acknowledges that the infection could get worse. He could possibly die as a result of that. But he's prioritizing the reason of, I don't want my mental illness to get worse, and I accept the possibility of my physical health deteriorating because I prioritize my mental health above that. So he's stated an understanding, he's communicating a choice, this refusal, he's putting in context of his preferences and his priorities.
So I sort of, this is a follow-up to just the last comment, and maybe I take a slightly different tack to that, because I really, I sort of wonder and I question whether his reasons for declining the therapy, do they really make sense? I mean, in his mind, perhaps they do, but from, and I'd like to say sort of a rational physician who might be taking care of him, I can see how it would feel really uncomfortable with the reasons that he's giving for declining the therapy.
Comments from anybody on the panel?
That's a really good point. Sorry, I'll dive right in. So I think you said a rational physician. One of the,
Misnomer?
no, I've got that one. It's a curious thing. was a very complicated person, and I'm saying this from a psychiatric perspective. It would be a challenge to take care of him on an inpatient psychiatric unit, given his sort of vacillating on basic decisions. And some of his behaviors, his decisions, were actually, they did take the form of behaviors. These were provocative behaviors. He was trying to affect the change in someone else. That provokes a reaction in people. And it's hard enough for us in psychiatry when we have some sense of what we're up against. On the general medical floor, and you've got 1,000 other things going on, this can be exhausting. So it can really test your capacity for empathy and for rational thought at times, because someone is kind of putting their finger in your eye and saying, I'm doing this, and I know it's irrational, but there we are. So that was sort of the emotional reaction a lot of the team members had to struggle with.
I'd like to add, I think it's hard to decide what's rational when you know the patient has made irrational decisions in the past. But if you imagine this case with a patient who doesn't have a psychiatric history, we can easily run into the same problem, which is patients who clearly have capacity, who have made decisions that various outcomes are worse than death. And then we run into a kind of no-win situation where we have to decide if their values and their choices about what's worse than death are rational. And that's a subjective decision. There is no standard on that. So, I think throughout this case, I continually ask myself, how would this be different if this patient didn't have a psychiatric history? Would we be comfortable with this choice then?
That said, just because somebody has a psychiatric history doesn't mean that they are unable to make decisions present day. And he was pretty clear that he would have preferred to die from medical complications rather than self-injurious behaviors that he's had in the past. And really did make a connection between going under anesthesia and experiencing a significant spike in psychiatric distress. He had a fairly significant history, trauma history, that triggered every time there was a surgical procedure. So he was very aware for himself, cause and effect, and did not want to experience that.
And I'll add, so I cared for him as a bedside nurse, and he was could be manipulative. He could know when he was refusing, because it meant that you would come back in the room several times, and he was socially isolated. So refusing, in a way, also meant that he got potentially more attention, more interaction with people, as opposed to being in the room by himself. This is a young guy. He's 25. He should be independent, living his life. And he had a psychiatric breakdown where he stabbed himself repeatedly in the abdomen. That was what caused a lot of his medical, like on the GI floor, history, the complications of this bile duct, him being hospitalized. He had a ileostomy that was putting out liquid stool continuously, so he always had to have someone cleaning him up. For a young man, that's not the kind of life he wants, and that was because his mental illness got out of control, and he took it out on his body. So from a nursing perspective, that fear of control, of lack of control, made a lot of sense to me if he knew that he felt out of control when he had anesthesia, because he knew that he was capable of harming himself and then relying more on caregivers that he didn't want. So he was a very interesting case because I felt bad for him, but it was also very frustrating because he was in an isolation room and he knew how to get you in and out of that room 20 times when your phone was ringing. He knew when you were busy. He knew how to get you to come back. So again, it was definitely not a black and white case as to what was the right kind of care to provide for him.
So one of the suggestions with regard to the decision-making part of it is how can we find allies for him to support his decision-making or help him come to a good decision? Were there strategies on a sort of daily basis, the fact that you had to go in and out of the room and so on, to prioritize his care for a particular day. Could you speak about that?
I was lucky that I was his friend after the psych team has gone and seen him. So they had come up with very clear strategies of how to refocus his attention and understand when he was overstimulated, because that's when he would refuse. If he got overstimulated, too many people in the room talking to him, and then he would just say, no, don't touch me, don't talk to me, get out of my room. So going in with a very clear plan, you had to prioritize what questions you were going to ask him in your assessment, prioritize what meds you were going to offer him because he was going to refuse most of them, and just be very focused, and then also engage him on a personal level. He liked video games, he liked Pokemon, so finding things that he liked to talk about while you were doing your tasks, so it didn't just feel like you were treating him like an object, but that he was a person, and that worked sometimes. He still has moments.
Yes, please.
It's like consultant on, I work in a career care team on the behavioral specialist, and when our patients are in the hospital, I'll consult, especially with their behavioral concerns. And I think that's useful because we have a baseline of where our patients are functioning and when they're not at their baseline. So that being said, do you reach out if he has a mental health team already to kind of get that understanding, like if this is baseline, is he kind of functioning or operating the decision making as he usually does? If this is where he is on the best kind of CME or being hospitalized, is he triggered, is he, kind of reacting from a trigger and not, in a sense, working in rational mind or working in emotional mind?
So from psychiatry perspective, that really is a critical question. So when we look at a very complicated individual like this, there are basically 4 categories that we're looking at. Is there a psychiatric disease involved? And then when we think about it, what does this person have? So we saw a diagnosis of bipolar disorder. Went back to his records, and there are many diagnoses that are in there. Bipolar disorder, schizoaffective disorder, schizophrenia, post-traumatic stress disorder, dissociative identity disorder. It's a catalog of practically every conceivable psychiatric diagnosis, and I don't know if any of them are accurate. But that's a question. Is this person under the sway of a treatable mental illness? And Ms. Noyes is here. She's a nurse practitioner that took care of him actually during long parts of his admission. Their assessment was very clear. This did not appear to be the exacerbation of a disease, something like bipolar disorder. So he was not manic. He was not showing signs of suggesting a depressive disorder. Not convincing psychotic symptoms. So that was reassuring in a way. Unfortunately, it left all these other realms that we had to account for. So another thing that we look at is the personality. It's who are they? That, unfortunately, there's a very rich description of that. Going back in the notes, goes back very far. The other areas we look at are what we call motivated behaviors. Is what is it the person does? Do they use drugs? Do they drink? Are there sexual behaviors? And that, unfortunately, was not a big issue. And the final area is the environment. What is it this person is surrounded with? And that actually was salient in this case. He was estranged from family, had very few supports. Looking back, it wasn't clear that he had sustained psychiatric treatment. So again, just to circle back to the part about his personality, I went back and looked at a note from 2011 when we had him on the inpatient service. And thank goodness for medical students. The medical student went and did a deep dive looking back at records from Shepherd Pratt and other hospitalizations. And he had been institutionalized most of his entire life. His contact started in his early childhood. He was in and out of psychiatric hospitals. He'd been on countless psychiatric medications. He'd been sexually abused by family. He was sexually abused in group homes. He sexually abused other children in group homes. It's one of the most disturbing histories that you can imagine. And it was one thing after another. And what's consistent throughout all this is his behaviors. So he tended to try to manipulate people. He was abusive. He would do things to get attention. And it's disturbing. It's a horrible thing. His upbringing was just terrible. So that was what was striking. This was a 7-year-old note, and he already had a running start for a lot of these behaviors. That included refusing medical care, refusing treatment for various things. So I don't want to go too far into the history, but just to give you a little background. So this was essentially who he was. This was his personality, unfortunately, surrounded by a lot of bad environments, and not a lot of people really taking interest in caring more.
Lori, from a social work perspective, knowing that history, is there an approach that you would have in trying to help him make good decisions or help ease any of his anxiety while he's in the hospital?
Sure. By nature, those with anybody in general will do very difficult things if they know that the outcome is going to be positive. Somebody who struggles with depression and probably doesn't scratch the surface for what he struggles with, there was no guarantee that anything positive was going to come out of this. He wanted to play video games, right? And yet he was still able to make some connections. I think that's important. The healthcare agent he identified was not a family member. It was somebody he had met 2 years prior when he was at Bayview. In looking at what kinds of controls he had, he was still reliant on other people. I think about what can you do to help this person get whatever control he can. For him, it was how he interacted with the medical staff and what decisions he could make. But for a life where he had none, right, kind of institution to institution, and then whether it be for psychiatric or for medical, he was returning to that. So there wasn't much hope that he had, but yet he had some things that he wanted to do. So I guess I would really have encouraged people to heighten his level of autonomy in any decision that he could, give him as many choices as he could. He understood the differences. Pull in those that he still had a connection with, and that was this one woman that he identified as his healthcare agent, and there was a person in a previous group home that he had stayed in touch with, that he was connected to, and who was actually an emergency contact for folks here at the hospital. And then just as much shared decision-making as possible. I mean, he didn't really have much of a quality of life at this point.
Yes.
Was his ileostomy permanent?
Yeah,
Closing
I
that.
think the expectation was that was going to be lifelong, based on all the other problems he had as a GI
And
tract.
because of how extensive, I've never seen an ileostomy so extensive. He had to be lying on his back all the time because any movement, it would start leaking, and he had open wounds. So that was the only part that we could engage him on as nurses, that he wanted to be clean, and we were the ones doing the care. So he let us do it. But yeah, his quality of life was very limited. Like, he couldn't even sit up and be in a wheelchair. And this guy should be able to walk, but he couldn't move because of the bag.
There's no way to fix that? I mean,
He had extensive, long hospitalizations, both this current one as well as past ones, to try to manage these.
So I'm a master's of biology student, so I just had a quick question. I guess this might be a good segue, actually. To me, I was wondering if instead of a question of rational versus irrational, is it a choice of dignity and the human right to dignity? Because it sounds like for him, perhaps the choice of death due to medical complications or just issues in general is just better than to a death due to his own making or due to his mental illness and his own capacity.
So I think that was maybe what Allison was getting at. If you stripped away the psychiatric history, and maybe he was saying, I don't want these things because I feel I'm suffering, my quality of life is so poor, and I just don't want to continue on these treatment paths. I prefer to pursue a palliative care or comfort care approach. That might be a different conversation than, no, I want to get better, I want to continue living, I just don't want to have the bad thoughts that I get after procedures. It's a difference there of dignity versus, what's his reasoning.
So I would point out, just to kind of clarify some of the thinking around this, he certainly did not want to die. He was clear about that. He wanted to play his video games. But, there was a different choice that I think he may have been looking at, which is that as a patient, especially a patient who can't even sit up, who has very little mobility and has a future that looks very similar, there are a few things you can control. You can't demand inappropriate treatment, but you can refuse treatment. That was one of the few places he could exercise any control over his life. And if he understood, and he should have understood to have capacity, his prognosis, that his prognosis was not good, even with treatment. A death due to a medical illness might have been in comparison to, even if he didn't die, simply another bad psychiatric break. Because if he has that bad psychiatric break, he has no control anymore. He has no ability to control his treatment. He has lost capacity. And whether or not he dies, that's not a state that involves much dignity.
So I guess, I think I said this before, that it's almost easier if he had a psychiatric break. Because then you can say, okay, well, capacity's out the window.
We would have treated it.
Yeah, it's cut and dry. But the challenging, one of the challenging issues with him was that he would make decisions in moments of intense emotions. Because of his personality, he was prone to, and his upbringing, he was prone to making decisions when he was very angry. So that wound that hasn't healed, he reopened that more than once in a fit of anger or pique. He isolated himself. He was not in contact with his biological family, but with his adoptive family. He had, he committed acts of violence against that family, but they were still trying to stay connected with him. He broke off relations with them, also in a fit of pique, the people that were closest to him. So he would make decisions that were damaging to himself as a way of lashing out at others, and later, one can theorize, he regretted them because he did want to live at the end of the day, which was, again, make these sort of on-the-spot decisions about capacity very challenging because he might be in an extreme emotional state that would pass away within a matter of minutes or hours.
And if you think about where he was developmentally, he had a very adolescent-like demeanor to him, right? And given the trauma and given the multiple placements that he's had, and then you have the physical limitations that he had, he was not always rational. All teenagers make decisions out of emotions, which is not the best. But so developmentally, we had to also think about where is he? He's facing these very adult-like decisions, and yet in a lot of ways, he was like a 15-year-old or
His affect was very childlike. Very. I don't take care of these patients, but in my mind, I just, in a way, kind of treated him, had the same sort of response, and tried to engage on his level that way.
His intellect, though, was intact. He had, going back, I saw on the records that he'd been tested. His IQ was tested 3 times from childhood up through his teenage years. There was a sort of anomalous one in the middle where it looked lower, but the other 2, the bookend ones, were consistently right around the average range. He did have some learning disorders, which obviously could have been remedied in a school setting. Unfortunately, the school setting he was in was residential and a very, very tough place. When you're dealing with severe behavioral issues, to attend to learning disorders too can be very challenging. But he also had strengths in math in particular that were actually beyond what was expected. So he was not intellectually impaired in any way.
So I wanted to ask Amelia before she has to go to talk a little bit about the impact of taking care of this patient on staff. It sounds like a really challenging case that has a lot of frustration associated with it, and as a toll, I'm pretty sure people taking care of it. So could you talk a little bit about how you and others were able to continue to provide care in a respectful way for him?
So, unfortunately, what we do is he didn't get a consistent nurse. If a patient has a good relationship with a nurse, they get that same nurse back every day. And in his case, because he would be so taxing on you, a lot of times nurses would say, I'm sorry, I think he needs to go to another nurse the next day. So for him, that was very hard because it meant if he had just formed a relationship and attachment to you, well, sorry, next day, new person, starting from square one. So it wasn't great for him. It was a strategy that, you know, we had to do to be able to not get so frustrated with him. We could take him in small doses, but, you know, he was on our floor for a extended stay, and that was one strategy that we had.
Just wondering if there are suggestions for the staff.
Yeah, I was going to ask too that sometimes the nurses will rotate who takes care of the challenge, but I see that pretty much every week on the Nelson floors. They're particularly just draining, exhausting patients. They'll be in rotation or at times it's actually tailored to the patient. If they have a better relationship with some of the nurses, they'll volunteer and take those and maybe have a lighter workload with the other patients on the floor.
I think just to correlate to that question, I got the sense in the back of the physicians' minds were, if we acquiesce to his refusal, is it born of our own frustration? You know, the day in, day out of trying to negotiate with him, if we actually just say, okay, fine, you can refuse, was that in some sense, you know, their own stuff of, I'm just frustrated, I can't handle it anymore, or do they still try to advocate for what they think is in his best interest? The medical interest, you know, trying to incorporate this psychiatric interest.
When you think about capacity, when I think about capacity, I also think about consistency over time. And I'm hearing that his view was not consistent over time, so I'm wondering how that plays into the assessment of capacity.
Well, there were different decisions at different times that he was refusing, so there might be inconsistency of today I'll agree to the IB and tomorrow I won't, so that kind of inconsistency. But at least with regard to the big ticket items, the endoscopy, he was pretty clear and consistent.
I can't help thinking about the fact that everybody has mentioned his mercurial nature and everything seems to focus on the behavioral problem as the fundamental issue here. And given that he doesn't have a single diagnosis that you can work with, and he's had multiple diagnoses, psychiatric diagnoses, are you confident that there's not more that can be done in managing his behavioral symptoms, even though you don't have a paragon to match up with? Has a lot been tried, and you feel his symptomatology is optimally managed, and this is the best behavior that you can get?
That's a good question. So yeah, he has John Smith's disorder, I guess is the right term for it. But you know, it's not. Like you said, he didn't fit the mold for bipolar disorder or psychotic disorder. There were elements of dissociation that would happen, and that was why he was so fearful of getting a major procedure. Something about the anesthesia where he was prone to that. It was highly traumatic for him.
Can you define dissociation for those that are in town?
Yeah, so it's something that can happen in response to trauma or stress, where you feel like you're the sort of prototype is you're outside of your body, floating, watching it from a distance. Everything is there's a sense of derealization when things around you are not really happening. And when that is with history of trauma, that can be linked to the event itself. All these things are a cluster, so something that would put him back in that sort of quasi-dissociated state can be very stressful for him, and that's partly why he didn't want to be part of going back under anesthesia. So, you know, in retrospect, is there some opportunity there? Is there some way we could work with him to figure out, well, is there some other approach for managing dissociative moments that can be brought around at the time of anesthesia? He was on psychiatric medications. I don't remember exactly offhand what they were, but a lot of them were for intense emotions, not necessarily for a psychiatric disease per se. It was for someone who's very strong temperament, prone to bouts of rage. Unfortunately, the only things we really have in our toolbox at times are the medications and psychotherapy, which can be a very challenging thing to do on the inpatient medicine floor, even in an acute psychiatric ward at times, just because the volume is high, the turnover is fast. You have to establish a good relationship with them, and I think that was a critical piece, having Liz and others who had that relationship with him. She actually followed him from, was it Meyer 8, Meyer 9, to Nelson, to one of the Nelson floors, just so he could preserve that continuity. He did seem to trust her and listen to her and have a good working relationship. So That's kind of a long-term view of it. We needed to have that kind of psychotherapeutic relationship.
I'm so grateful that I'm just arrived from Africa as a postdoc ethics student. I'm very interested in really touched by this whole scenario of how doctors are facing ethical dilemmas to do such a big thing. So my question is there anything in the medical, I'm not a doctor, is there anything in the medical guidelines that doctors can, in this case, like really can take something and do something beyond the patient's agreement? That, I mean, is it unethical? How do we weigh his death compared to his health? Are you allowed to go beyond and take decisions in that way, ethically? And really, how far are you supposed to go as doctors? What is protecting you as medical doctors when the decision to make like this one is at hand?
And I think the last paragraph in the write-up sort of gets to that of could the physicians take it in their own hands, be paternalistic and say, we're just not going to listen to your refusal, we're going to do what we think is best for you. In today's world, in the US, no. If we think the person has capacity to make their own decisions, we want to respect their autonomy, respect them as a person. We try to work with them, we try to convince them, persuade them, give them the information they need to make a sound decision, but ultimately, if they are refusing, the physicians would have to honor that.
And I'm not sure if anyone who is training is still here, but what about kind of developing trauma-informed care with them? I heard you talk about just the decades of trauma that followed this gentleman and kind of thinking of treating him in that way.
That's a good question. Liz may have thoughts on that. Yeah. I think part of the challenge with this was there were so many moving parts to try to tailor it. The landscape kept changing, and I would hear about it on rounds most weekdays, and it was just an unending series of challenges and obstacles and things like that.
Yeah, of course. I mean, that would have been ideal. Mostly what I was doing was support therapy at the time. That was just sort of like dealing with a daily crisis. But as an outpatient, absolutely, that would be.
I guess kind of thinking as a team in the medicine floor that medical procedures can be traumatizing for many reasons, and just kind of as a whole kind of working on being as trauma-informed as we can, whether we're the nurse or the physician or whoever kind of caring for some of the difficult patients we get here at Hopkins.
Absolutely, that's something to hit.
It's a good point. We've had to, in the emergency department, we've had to adopt some of the, it's not the most sophisticated thing, but it's some of the kind of fundamentals because the patients that come in through our front door, oftentimes there is a trauma history. It's the cluster of psychiatric problems, poverty, all this traveling together. People bring a lot to them, or with them to the front door, and our nurses have to be very mindful of that. And there are certain things which can be a trigger for aggression, self-injurious behaviors, things like that. So they've had to be kind of methodical and thoughtful about how they approach patients, how they talk to patients. Putting hands on patients is a very meaningful thing for people that have trauma history, and I think they've adapted and some of the kind of the basics of that down there very well.
In pediatrics, child life is very helpful in preparing children for surgeries, through visualizations, through just practicing and simulating what will come. We talked to him about actually preparing him for a procedure, and if that's something that he would be interested in, he described this sort of free fall that he would go into as he was getting anesthesia, and it terrified him. So having an awareness of trauma and having the inability to remove that barrier was a really difficult position to be in. And at the end, he just wasn't interested even in receiving that kind of assistance to sort of prepare form, a procedure in a different way.
Listening to various comments from all of you, one thing that's been sort of popping back and forth in my mind is how to, as you're a healthcare provider or even on an ethics committee, separating yourself from your own preferences in similar situations. In other words, standing back from, oh, I wouldn't want to live this way, I prefer to die. Which, of course, really ought not be part of your involvement or assessment. Any thoughts on working with that?
I'll dive right in. No, it's an excellent point. We always have to kind of take our own pulse in moments like that. And you know, as we were talking earlier about what a miserable life it was, and he's bedbound, and he's open wounds and things like that. From an outsider's perspective, you know what, death with dignity sounds okay. I don't want to go through that. I wouldn't wish that on my worst enemy. He didn't see it that way. He wanted to live. And that's, you know, I also see geriatric patients, and we run into a similar situation with folks with advanced dementia. Everybody around them says, well, this was a highly successful person, and now their memory is gone, they don't recognize family. What a terrible thing, that must be awful. The patient's perspective is actually very different. They don't want to die necessarily. If they do, you have to worry about depression, things like that. But the point is that we can't see in there, they sort of look out from their perspective. But he made very clear how he saw things.
I just wanted to make a point. I don't think he was super unhappy. I really don't. I think he was actually fairly content. He was getting to lay in bed. He was playing his games. I mean, he had a lot of attention when he wanted it. He knew how to get the attention, as we heard. And he was able to not have the attention when he didn't want it. He was very interested in having a maternal presence around him. And nurses helped to provide that. I think his friend helped to provide that because he would sometimes do things that were manipulative when she had been in to visit him as recently as he would have liked, or as much as he would have liked. So he would do something, and that would force the team to be in touch with her, and then she would have to rush in to kind of save the day. I'm not sure that he was. I don't think that his quality of life, according to him, was really all that bad.
Allison.
Yeah, so this is hard. I think that the idea of do you need to separate yourself is tricky. On one hand, sure, you have to be careful not to impose your own beliefs on patients. On the other hand, you can't say don't be empathetic, don't imagine what it's like to be in their shoes. That's part of your job, is to try and imagine what it's like to be in their shoes. So, you do both. You try and imagine it, and then you try to make sure that your preferences and beliefs aren't overweighing theirs.
Most of what I'm hearing is a lot of traditional psychiatric medical care, and I'm wondering that although there was the visualization, is there anything more that you could do outside the field in more of an integrative medical approach or alternative treatments that would be maybe non-invasive to him that perhaps he would be open to? Maybe they would work, maybe they wouldn't, but so far nothing that is being done is working, so what might there be to lose?
Suggestion on integrated therapy?
Yeah, no, it's, I don't know if you had any particular modalities in mind. Those tend to work best when you have someone who is open-minded about it, who is, and tends to be more psychologically minded, really, and is curious about themselves, curious about alternative approaches to things. From what the team had been saying, I don't know if we had that kind of template to work with. A lot of his behaviors, there's a lot of hot stirring that's going on by him to have someone with his background and temperament to get them to slow down and and to be more reflective and think about it and to consider alternatives would be a real challenge. I don't know if Liz, if you have thoughts on that.
No, I do know that he's been institutionalized in various forms most of his life, and so I know that various institutions try different things. So, for example, he was in a state hospital for a number of years, and on all sorts of medications. I believe probably at some point he had tried acupuncture or tried some of these other things. I can't point to a moment that he had.
Okay. Well, and to what goal? What would be the end goal? Is the end goal to help him live the rest of his life the way he wanted to and honor that, or to get him to change his mind based on what others might think is best?
I would, my thought would be more that would be another approach to address some of the psychiatric issues that may or may not work. And you're right, he may not be open enough to even want to explore that. No, I don't think it's to change his mind. I think it's just an alternative, an option that may or may not work. And it might be worth approaching him, but
I think there's a lot in that. You never want to give up. And this is a kid who had been really burned by the institutions that he was in, severely injured by them. They had tried, he was on Haldol as a young child. That's a pretty potent medication. I was just stunned by some of the interventions that happened. So this is a kid, I can imagine him not wanting any part of anything. So yeah, he was very ill-served by his time in institutions, and I worry that would have influenced how open he would have been to trying anything.
I'm going to shift gears and I'll hold on your comment. So just looking downstream at what might happen to him if he does get sicker, we have this friend that's been identified as his healthcare agent. How would people engage her, or both of them together, in terms of making future decisions, the advanced care planning of what would you want if? So if you were sicker and we need to bring you to the ICU because you're septic and all the various things that could happen downstream. He's saying, my goal is to live. I have, a quality of life that I'm, accepting of and, get enjoyment out of. But at the same time, he's refusing particular things that are going to have bad consequences. So when those bad consequences happen, what should the team's response be?
I just wanted to ask one backup question. You said healthcare agent. Now, does that means to me that he completed an advance directive and named this person consistent with Maryland law, which is quite simple. Okay, just wanted to
so based on, with the ethics consultant's help, he designated her as his healthcare agent.
Okay, thank you.
So I'll throw out a question. So we posed it to him, and my own research work has looked at sort of preferences for control, and we've talked a little bit about giving him some sense of control over making decisions. But with regard to hypothetical future decisions, you could have a few different scenarios. One, when it's advanced care planning and you have an agent speaking for you, you could say, I want my agent to just go with my wishes. My independent decisions, follow those by the book. You could have some people that say, once I am unconscious and can no longer make my own decisions, I want to defer to my family member. That healthcare agent is going to be able to weigh the pros and cons of the situation and come to a decision themselves that they think is best. And some people will defer to that decision. And then a lot of people are going to be in the middle of some kind of shared decision making, shared preferences with their surrogate, their healthcare agent, where it's a little bit of what I think, respect those, my values and preferences, and a little bit of what you're getting a sense of is best for me in the situation. So some combination of that shared decision making. If he said, when I'm unconscious, you hear my wishes, I don't want this procedure, I don't want other interventions, but my healthcare agent, if she comes along and says, do them, go with her decision. Would people feel that is respectful of his autonomy to, go against, a decision he's made when he's conscious of no, and now a healthcare agent is saying yes. He's saying defer to her. What do you think about that? Is that respecting him as a person?
Well, I would say yes, if he directed you to do that, we assume that if he directed you to do that, and to honor the judgment of his agent, then I think that does respect his wishes.
I mean, he chose that person for a reason. That was the person he chose, so there is a wish there. This is a person that there's a connection to, cares about, feels that they might know him well, so that I do think that is, you could say, no, I don't want anyone, and this is just if I go off and something happens, I'm not being very easily say that.
So usually our advanced care planning and the advanced directives themselves focus on what, the decisions. Do you want the ventilator? Do you want the feeding tube, etc.? This is a question of advanced care planning of the how. How do you want decisions to be made? So it's a little different twist than our normal process of people filling out advanced directives on how much they want to share that with the other person. So we've heard a lot about this case. Any other things you think we need to explore in terms of trying to help him?
I'm just curious, what was the attributes that he found in this moment to name her as his care director? Was that ever investigated? And if so, what was really brought of that? I'm just wondering, because he seems to have so much instability, what was so stable in their relationship?
I think in one aspect it was this maternal figure. So again, having somebody that he saw as a motherly influence, and maybe he deferred to this mother figure in making decisions. And anytime he refused, if she were around, and she might say to him, "No, you've got to do it," and then he'd acquiesce. She'd be able to convince him, where the healthcare team, with their various negotiations and so on, wouldn't be able to. Her laying down the law and saying, "No, you've got to do it," he would say, "Okay." So there was something about that dynamic, whether it's a mother figure or otherwise, that influenced him.
I want to believe it was sort of strangely insightful. There's this voice in his head that says, I make bad decisions, I make rash decisions, impulsive decisions. This person doesn't. There are probably psychological underpinnings. He seemed to form stronger bonds with female staff and this woman that he met at Bayview. But again, I want to believe that was actually what was driving some of this, that he had some insight into his behaviors, because again, at the end of the day, he really didn't seem to want to live.
I mean, I think it's also interesting, we had very little knowledge of this man's past and what is, has happened and how he formed this bond. But it suggests he is capable of trusting someone, right? We don't know what she did or what she said, but somewhere along the way, someone gave him a reason to trust, and he did take it. So he wasn't incapable.
I don't think anybody got the sense that she was in it for any other reason than to just take care of this young man who really had no one. Very sweet, very kind.
Where is he now?
Do you want the story? So unfortunately, his condition continued to progress. He actually got well enough to leave this hospital, but soon thereafter got admitted to another hospital, and the infection continued to progress, and he ultimately died. So the foreshadowing of what could happen to him actually did come about. And I think left the healthcare team, again, questioning, did we do the right thing? Did we honor him as best we could? Did we help him make good decisions as best we could? Just since you're new, so I'll take you first.
Hi, I'm not sure the legal side of this, but just for like mental illness in general, if 3 or 4 days out of the week you guys like deem them incapable of decision making, at what point do you just say in generally like you're not capable? You may have a good day, but those days are bad. At what point do you just say okay, he's not capable?
So capacity, there can be variation in capacity. So a medical illness can clear up, a psychiatric disease can stabilize, and the patient can regain capacity to make decisions. So a physician's ability to make that determination of capacity is actually fairly limited. Only a judge can say that this person globally lacks capacity, and that's where I'm not a lawyer, but that's where they use the term competency. So only a judge can say this person is incompetent. They require guardian or whatever they deem as the next step.
Sorry, just make a point that just because you don't have capacity doesn't mean you can't make decisions. So for example, maybe you're going to ask about whether you can have a craniotomy, right? And you don't have capacity to make that decision, but you do have capacity to make decisions.
Yeah, so we talked about the sliding scale notion of capacities, simple decisions that don't have high stakes, high risk. You might be able to make those decisions. The complexity of rationalizing, the pros and cons you could do. The more complex craniotomy and so on, you really need to make sure that they have full ability of those 4 criteria for capacity.
Capacity, as I understand it, is contextual. And so a person might have the mental capacity to fill out a will. Like, I have this property, I want to leave it to so-and-so, and of course you have to have mental capacity to have a proper will. That's different from the complex medical decision making that the folks have been describing. So it's and I would imagine that you all have even seen one kind of medical care. It's so, I'll use the simple term basic, that yeah, he can understand the process and say yes or no. Something else, no. So that's how I understand the capacity issue.
I want to point out here that this can be dangerous, right? If you are asking people about what we think are simple medical decisions and letting them make those decisions, and we do that continually, and then suddenly they say no about something that's big. We've now created documentation in our medical record that says this person can make decisions, and now suddenly we don't want them to. That can be that's a bad position to put yourself in the hospital in, to suddenly say, when they say something we don't like, or when the stakes are big, suddenly we decide you don't have capacity anymore. So if you're questioning the little decisions, it's worth doing the work up front. Because if those little decisions turn into bigger decisions, and we didn't pay attention until it was big, or somebody said something we didn't like, we're put ourselves in a terrible position.
Just because they say yes, you still have to do the assessment.
Ask yourself, if they had said the opposite, would I have a question about their capacity now? And if the answer is yes, you should have a question about their capacity now, when they're agreeing with you.
When do you bring in chaplaincy, and did you do that in this case?
Obviously, if there's a spiritual dimension to the person, for this particular John Smith, I don't think he had any religious background. I think a chaplain can certainly provide that additional support, emotional support or otherwise. Some other person that could go in and just talk with him and be with him. I think it can be offered, even if they don't have a spiritual dimension or religious affiliation. I don't know if it happened in this particular case, being offered, because there was no evidence that he acknowledged any kind of spirituality.
What kind of evidence did you want to see?
Well, asking him the question, would you like to see a chaplain?
Just really quick, since I think we're almost done, but since we're talking about capacity, I think it's important to state some very basic things, which is that patients have capacity until we document otherwise. So if you don't think someone has capacity, it needs to be documented. And that is a pretty complex process. Not every clinician can do it, and if you're unsure, please call legal, because we don't always do the best job of that, and that can get us in a lot of regulatory trouble.
I'm curious to know if anybody followed up with the hospital where he died to see whether they faced the same issues of his mercurial decision-making and things like that, how they dealt with it.
They did face similar, they'd taken care of him before, and during that last hospitalization, were facing the same issues.
Thank you very much. Sorry to repeat myself. As a student, I'm beginning to become very curious about the issue of autonomy when life is at stake. And I have very uncomfortable feeling about when we are expected, know that this person has autonomy to make decisions. And his life at the same time, the autonomy that we are giving him will kill him automatically. I think maybe this is the time now. It's people we need to review the autonomy of people. I know you said we do not want to impose our views and our preferences on the autonomy of the patients. But, and you are also saying, but you also have to be empathetic. I don't think empathy was done here. Autonomy was taking control, and that autonomy led Smith to die. That's how he is right now. He's dead because of the autonomy. So now, as ethics people, we need to look at this one. This has to be reviewed again because it has implications on the life of people. Thank you.
Yeah, so you're not alone. A lot of people are struggling with that right now in a lot of different contexts. And I guess all I would say is that, especially as clinicians, having a very clear conversation within yourself about whether you are comfortable with how we currently allow people to make decisions when they have capacity is important. And knowing what you want to do if you feel your own values are being violated by respecting the current status of how we do allow people to make decisions, including refusing treatment that will lead to their deaths.
There's always going to be that tension of beneficence versus respect for autonomy. The clinicians want to do what they think is best for the person, treat their medical conditions, but at the same time we have to respect their wishes and their thoughts, and if they have the capacity to do so, trying to help them make the best decisions they can, but ultimately, in our world, respecting their autonomy to make those decisions. So I thank you all for your participation in a great conversation.